I have to say, we were just with the students. I have to say, really, when I think about Dr. Reece, it's really about excellence in medicine. He has so many qualities that we're always looking for. Somebody who's been a researcher. He's got an NIH-funded grant, which he does with about genetic defects. Has many leadership positions and mentors, faculty. He has over 500 scientific publications, and he's a really great person. And he's really ethical, and he has great work ethics. In fact, he was telling people, even on the airplane, he always brings a bag of his work so he can do it all the way till he landed today, and he'll do the same thing going back. I really had the pleasure of having Dr. Reece speak at the National Medical Association recently. He's been very involved in the OBGYN section there, but he spoke to our Rav Venable Excellence in Ophthalmology Research Program and really gave a wonderful talk to the underrepresented minorities there, just about research and life and medicine, and I certainly appreciated that. He certainly gives a lot of talks, and today we'll be certainly hearing one of them. But I wonder if the fact that his daughter's getting married in 2 weeks or so, whether that will probably be one of the most important talks he'll be giving. But today, we certainly are very honored to have Dr. E. Albert Reece speak to us at Rosalind Franklin University of Medicine and Science at the Chicago Medical School. Welcome, Dr. Reece.
Dr. Olivia, let me thank you for inviting me, and I want to thank President, the Dean, for hosting me. It's a privilege to be here and to address this audience. I have the privilege of being invited from time to time, but it's a special privilege and an honor for me to always give a moral or an endowed lecture. And this being the Marshall Falk Distinguished Lecture is of special significance. And so let me start by paying tribute to one, of course, a thank you to those who have hosted me and invited me. But let me start by paying tribute to Dr. Marshall Falk, a former colleague dean, and as you can see, someone who basically has spent his entire life at this institution. This is extraordinary contribution. 40 plus years serving as faculty, chair, then dean. He has 2 years on me. He has 17 years of dean. This is my 15th year. Professor and Dean Emeritus, Chairman of the Board of Trustees, and the first Chancellor. So it's someone who clearly, as I've reviewed his history, I can see has clearly made an extraordinary contribution. So for me, it's an honor to speak at this time. What I'd like to talk about today is really the impact academic medicine makes on communities, locally and globally. And as I go through my talk, you'll see that, think about if we didn't do it. Think about if academic medicine was not as engaged or as involved as we have been. What would the world be? What would the community be like? So just think about that. I will not focus on the negative, I'll focus on the positive. But you reflect on the negative if we weren't there. So I want to speak on the health of a community. How is that assessed? And when I use the word community, I'm referring to the local community around here, but I'm referring to the global community around the world as well. And it's all about the global burden of disease, some of the barriers to health, to good health, and the role academic medical centers play. And I'm using the word academia in a generic way to the success for a world. So let's start by going to a definition. The World Health Organization, as you can see, defines health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And so that is the totality of health we want to focus on: physical, mental, and social well-being. You'll see the World Health Organization considers some key determinants of health, and they are social, economic, physical environments, and also one's characteristics and behaviors would comprise those key components or key determinants. The the HHS, the United States Department of Health and Human Services has issued a number of health initiatives. Healthy People 2010, Healthy People 2020, and so on and so forth. And you can see that it uses a science-based approach in its proclamations. It has set goals and benchmarks for improving the health and reducing disparities and inequalities. So just some of the things that HHS has championed. Well, let's start by looking at the local burden of disease, within our country. I want to always, as much as possible, make reference to where I am. I'm in Illinois, so I'm going to be in Chicago, and I want to make reference to that because I think it would be more relevant to our students and to folks who are here. Life expectancy at birth, the projected life expectancy in Illinois, you can see, was 79 years based on the 2010 data. Chicago was 78 years based on 2010 data. But more importantly, those projections represent a 7-year increase from what it was in 1990. File that fact. Let's look at the world, life expectancy. Look at the United States, 79. Look at the UK, 89. China, 75. India, 66. South Africa, 60. So we see again some disparity in life expectancy based on the projections from birth. Now, if we look at other indicators of health, and the WHO likes to talk about non-communicable diseases, and they're also obviously communicable diseases. When you look at the worldwide platform, if you will, and just take out 3 diseases or disorders. Worldwide, almost 39 million people have HIV/AIDS. But I'm going to have some consistency here in how I present it. In 2014, you'll see a little over 1 million persons died from HIV/AIDS or related causes. You'll see 198 million people have malaria. This is worldwide. In 2013, a little bit more than 500,000 people died from malaria. Watch the trends. Look at diabetes. Diabetes is a rapid rising problem coupled with obesity and often referred to as diabesity. 9% in the world. And you'll see in 2012 about 1.5 million people, very similar here, died related to diabetes. But what you notice here is that malaria is outstripping HIV/AIDS. And the Gates Foundation has recognized that and is putting much of their funds toward malaria and now almost nothing right now, very, very little towards HIV/AIDS. So watch that trend. How about United States? HIV/AIDS, 1.2 million people in the United States, but look at the death rate. In 2013, approximately 14,000 died from HIV/AIDS related causes. The good news is that malaria, we've had it eradicated since the 50s, but there's still about 1,500 cases reported each year. So it's eradicated, but it's a global environment, so there's travel back and forth. Now with diabetes, this number is old. It's about 29 million people with diabetes in the United States. And for those students, about half know they have it, about half know they don't even know they have it. But now it's the 7th leading cause of death in America. Diabetes is now will be in 2030 to be exact, the 7th leading cause of death in the world. So you see, these are some high areas. I usually say to folks in my university that, what should we be spending our time on? And I said, I like to focus on things that result in high or significant mortality, morbidity, or disability. Not to the exclusion of everything else, but if we have to disproportionately invest, we should invest in things that are killing people, making people sick, or making people disabled. So these are just an example of some of the high ones. These are people making people die. How can we in academic medicine make a difference? So start with this. Common barriers to good health often include some type of health disparity or inequalities. We may need a well-trained workforce. We may need research so we can apply to the population. or promoting excellent clinical care focused on patient quality and patient outcomes. So some of these are barriers, not a total number, but just some of the possibilities. Well, let's look at some specific barriers now to good health. And I want to focus on Illinois. And I want to focus right in this region here so we can relate to it. In Illinois, for example, specific barriers is 30th for overall health, 40th for preventable hospitalization, 28th for diabetes, 25th for obesity, 35th for ID, 22nd for people uninsured or underinsured, and 32nd for health disparities. When you look at the Cook County area, you'll get a flavor. 64 out of 102 for overall health, 87 out of 102 for quality of life, and 81 out of 102 for clinical care relative to uninsured, primary care, preventable hospitalization, people receiving a diabetes screening, mammograms, etc. So that's where we are. And those are some of the specific challenges. Keep in mind again, how can academic medicine make a difference? I'm laying the groundwork. I'm not there yet. So be with me, stay with me. But so these are some of the challenges that we have. So the question is, how can academic medicine make a difference? Working locally and globally. Let's start by looking at some of the critical roles that we play. One, we conduct research that is crucial to providing the pipeline of drugs to address diseases. We also study, investigate disease conditions and the causes of significant burdens to developing countries. And of course, we train the workforce. So those are some of the things that we do. But what else do we do? When we look at reducing the burden of HIV/AIDS, for example, which is one of the major big ones in both the world and the United States, for example, we see the history. I'm not going to go through this, but we know that very well. In the 80s, that's when the disease was rampant. There's 270 cases reported of pneumocystis carinii at the time. And of course, you saw the Congress invested $15 million. But most importantly, the important point I want to make is this part here. There's partnership between the government and academic medical centers that first identified HIV or HTLV3 as a cause of AIDS. And this work led to the decline in global AIDS-related deaths from 23 million in 2005 to 1.6 million in 2012. Academic medicine playing a part not only in the identification of the virus and the causation of the disease, but also the impact. The various antiretroviral drugs also came out of academic laboratories. So more work is needed to eradicate disease, and AMC continues to play a role. Now, this is one of the difficult things that we've reached a point where a vaccine is needed, but it's very, very difficult. We have a large institute of human virology at Maryland, which is headed by Dr. Bob Gallo, who discovered the HIV virus. And they've been working on the virus, a vaccine, for some time. Tough. I was talking to Tony Fauci recently, and he said, HIV virus, the virus there, does not generate a natural antibody response. So to try to find a vaccine that can do that, you have to be better than nature. And I thought it was a very nice way of putting it. He said that's the problem we're up against. We have to find a way to have the body respond with an antibody load that can override the infection much better than nature would, and that's the problem. So Bob Gallo has now a vaccine candidate that just got funded by Gates Foundation and the Department of Defense and NIH to begin clinical trials probably a few months from now. It's going through IRB. But it's where we are. It's a tough situation. We've not been able to establish a vaccine. So the best we can do right now is to use antiretroviral therapy to at least create a functional cure, make the virus be quiescent and not progress to AIDS. But again, this is what academic medicine is doing. Now let's look at the incidence in the U.S. 1.2 million people. In Illinois, 43.5 people, 43,500 people. In Chicago, 25,500 people. How about Maryland, my home state? 30,000 people. In Baltimore, where I work, 13,000 people. And when you look at Maryland and Illinois, 7th and 8th highest reported case of HIV in the country. So that's our platform. That's our working platform, collectively. But I'm pleased to say that we are doing something. We'll see that right here that Rosalind Franklin University Medicine Science is actually involved. The AMC, the University of Illinois College of Medicine, has the HIV/AIDS Community Clinic. You'll see Northwestern Feinberg has a program. And again, there's an HIV/AIDS drug discovery research right here in the Rosalind Franklin lab. And of course, the work, as I mentioned, that Bob Gallo is doing in the Institute. So academic medicine is doing their part, recognizing the need and is actually making a difference. I want to share with you a little bit of what we're doing in Baltimore.
On National HIV Testing Day, the University of Maryland is mobilized on the streets of Baltimore in a neighborhood challenged by disparities in healthcare and one of the highest HIV rates in the state.
I want to see smiles on everybody's faces today.
The School of Medicine's Institute of Human Virology is partnering with Walgreens Pharmacy to provide free HIV testing and other important health services.
Blood pressure, oral health, education. We're able to offer nutrition, healthy lifestyle, BMIs.
School of Medicine students are among the volunteers.
So for every person I'm able to drag in here to take their test, that's one more person that knows their status and one more person who can spread the word or their knowledge about HIV and AIDS.
So that is just a little vignette of what we can do, academic medicine, to really address some of the problems in our own community, and that happens to be a local community. But let's go a little further. Let's take it globally now. Let's move the plane up outside the United States across the world. And look at some of the causes of death worldwide. About 10% of the deaths worldwide among children, for example, is due to enteric diseases. Kills more than 2,000 children every day. What's interesting is that the death rate is so high that it exceeds AIDS, malaria, and measles combined. So there's a study that was completed this year, maybe 9 months ago, called the GEM study. And you can see it's the Global Enteric Multi-Center Study. It's an NIH large study. It was funded by the Gates Foundation, rather. It's a 3-year study that enrolled 22,000 children under the age of 5. And what they intended to do was identify some of the main organisms that were involved in these enteric diseases that are actually killing so many kids. This study was led by one of our faculty members, Myron Levine, who runs the Center for Vaccine Development, and they identified these: rotavirus, cryptosporidium, Shigella, and enterotoxigenic E. coli. What's interesting is that, one, the results provide really good information regarding what are the primary causes of these enteric diseases. But also vaccines are being made against rotavirus, Shigella, and these have been made. This is being made or being explored. So again, identifying the causes and trying to attack them with appropriate therapeutic intervention is something that, again, academic medicine is doing. And this was a multi-center study. Although our group led it, it was a worldwide study, providing academic medicine, providing an impact on global health. Let's keep it worldwide. And this is everybody can relate to, Ebola. It sort of generates a certain amount of buzz within everybody. You remember the Ebola crisis. We all thought that it would just consume us. And again, academic medicine came to the rescue. Without going through this timeline here, you'll see this is kind of the outbreaks of Ebola across the world. The year, the number of cases, and the number of deaths. And you can look right across and you see that's a timeline. But look at another timeline. This is a CDC response to Ebola. And you can see virus, you'll see what happened in Guinea, what happened in Liberia, and what happened in Sierra Leone. Looking at the x-axis, you'll see the timeline. But the shifts, you'll see the virus, the sort of the epidemic, and then began to taper off. Now the next slide, I think, puts it in better perspective. You'll see the number of, you look by the numbers, for example, the total number of cases, total number of deaths, healthcare workers trained in West Africa, and the CDC deployment. Thanks. And so you can see the number of views for the CDC Ebola website at the time, just an incredible amount of, when I use the word excitement, I mean, it's almost scared. You're scared about what is happening and what could possibly happen. So it was a big deal. The question of what academic medicine did. Well, if you want to put it in different perspective, you'll see the three countries that were primarily involved: Guinea, Sierra Leone, and Liberia. Just take two of them, for example, Guinea and Sierra Leone, and you can see these are total suspected cases, 17,500. Look at the number of laboratory, you can see these are the confirmed cases by laboratory samples or studies. And then you can see the total deaths distributed between Guinea and Sierra Leone. So that we remember very well. The question is, what has academic medicine done? What kind of impact it's had? And the AMCs were asked to assist. In fact, there was a notice that went out from the AAMC to all medical school deans. I'm sure Johnny might have received it as well, asking what we can do and how we can become involved. Why? Because most medical schools have well-established, robust research programs. They're internationally renowned experts in virology, infectious disease, and how can they become helpful to the entire system, not just ours, but the world. We want to study how to combat diseases, and we typically have long-standing partnerships that we can actually get this partnership engaged. So we have a platform, we have an organization that can come to bear under these circumstances, and so the AMCs were called into action to address this Ebola crisis. We recall our colleague in Nebraska, for example, got the brunt of it, and so did Emory get the brunt of it. Many of our other colleagues around the country were preparing themselves. This is work that we did this is one of our basic science faculty, Alan Smalljohn. He is an investigator who was one of the co-inventors of the antibodies in the Ebola vaccine cocktail that was used for that first doctor, I forgot his name now, the first doctor who came back with Ebola, remember him? I forgot his name, but he got the serum cocktail. So that was work that Alan had done before, not even thinking it would be useful for anything except being on the shelf. So it became very useful. Dr. Mike Levine has been leading for the last 40 years the Center for Vaccine Development. And we have a center, a Chile center, and we have a Mali center, and we have a Baltimore center. Well, there was one Saturday night I was home, and I got a call from Mike Levine, just during the Ebola crisis. And he said, Al, I just got a call from WHO, and they would like to know whether we would be willing to test an Ebola vaccine candidate right away. And I said, well, Mike, the answer is yes, but let me work on it in between before, you can get started, answer yes, but I'm gonna have to work on it. The reason why this is an important thing for the world, this is at the time wasn't important for Baltimore or for Chicago, but right now the world is in trouble. And so the Wellcome Trust funding agency collaborated with Oxford University and with NIH, and they wanted to create a vaccine candidate. The vaccine candidate was actually created at NIH. Wellcome Trust would fund it, and Oxford University would do a preliminary test to make sure it is phase 1 study for safety. And they wanted us to now test it. We have big sites, testing sites in Mali, Africa. So we have CD Mali. And so within a week, we're able to get it through our IRB. Because folks are human beings like us. And they realized that this is of great importance to the world. And as the usual IRB that would normally take weeks, began to take days, because academic medicine realized we have to come to bear. And so this became a major study. We eventually had a testing site in Baltimore as well, just for a very watered down form of the vaccine. And many of you know that there's a vaccine for Ebola that has been published recently in the last 8 months. So academic medicine responded very well to the Ebola crisis, and we know the rest of the story. Now, admittedly, it was academic medicine not alone. The government played a part, sending the military in and putting tents and appropriate protection. The CDC played a role. Everyone played a role, but academic medicine played an important role in developing a vaccine, working collaboratively to make this happen. These are just some of the emerging and re-emerging infectious diseases worldwide. We're working on some, and we're not working on some. Somebody else is working on some. So this is just to give you a flavor that the world has problems, but academic medicine is here. And these are all over, from anthrax, bioterrorism, to H1N1, to cholera. Cholera now is in Haiti. Because of the earthquake, now cholera is increased in Haiti. I'll tell you a story in a moment, but this is going on. And you can see, you have SARS in the Middle East, you have MERS in the Middle East, SARS rather in Asia, in Tokyo, primarily, but MERS in the Middle East. So these are various pockets of infectious diseases that have emerged or re-emerged worldwide, some of which we're involved with. Academic medicine is involved with many. And this is an example here of combating diseases worldwide. This pandemic, H1N1 influenza, that you know occurred in 2009, cholera vaccine, cholera disease, and it's interesting. Several years ago, one of her faculty did a cholera vaccine, but nobody wanted to commercialize it, so it sat there. Well, I don't want to say fortunately, but the timing of the earthquake in Haiti was of such that cholera has broken out. So now a company is now commercializing that vaccine. It's an oral vaccine for cholera. So again, academic medicine is providing the kind of response that the world needs. There's tick-borne disease, and there's MERS, and there's SARS. And so that has happened in the world. Academic medicine is coming to the play. So let's talk a little bit about back locally. Let's get back down to our local community. And health disparities is an area I want to talk about. Let's start with Chicago. When you look at Chicago, for example, and look at the number of Chicagoans living in food deserts, you'll see that from 2006 to 2010, the number has declined, and that's a positive. We see it's 383,000. You look right below that to the percent of adults who have been told by a doctor that they have high blood pressure. Well, it's above the target. You're at 30.4. So it's an increase from 2005. Not much higher than the target, but has not come down. When you look at the asthma hospitalization rate per 10,000 residents, it's quite a bit above the target of 22.6. And looking at breast cancer death rate in black and white women, that's also well above. So you can see the number on that screen. You may not be able to see it from the back, so let me read it for you. The goal by 2020 was to target a closing of the gap by 50%. It's not heading in that direction. It's actually diverging. So we have some health disparity statistics right in your neighborhood, right in your backyard, that needs to be addressed, like in most other major cities. What has academic medicine been doing about this backyard issue? Well, in the Healthy Chicago initiative, other activities include the Institute of Medicine of Chicago announced the receipt of $290,000 in funding to combat health disparities in underserved communities this year, 2015. Again, I'm pleased to see that your university is also a key partner in this effort. Academic medicine. There's a New Life Volunteering Society health clinic founded by the University of Illinois in Chicago in 1999. But we also see that, I was just talking to the medical students earlier about their neighborhood clinic. So I'm pleased to recognize you students that second-year students, these were second-year students I was talking to at lunchtime, second-year preceptorships at predominantly Spanish-speaking clinics exist. And so you're doing your part in making our nation a better place. Sinai Urban Health Institute is also partnering with Chicago Medical School to really make a difference. So those are the things that are happening. Now let's switch to Maryland. And how are we doing? Well, we have problems. And you look at infant mortality rate, for example, you see 2 times higher in American Indians and Alaskan Asians, almost 3 times higher in Black or African Americans. HIV incidence, 2.2 times higher for American Indians and Alaskan Natives, and almost 12 times higher for Black and African Americans. Rate of women who received later no prenatal care, almost 2 times higher for Black or African Americans, and 2 times higher for Hispanics or Latinos. The proportion of adults without health insurance may change with time, but that's, as of the last statistics, was 1.4 times higher for Asians or Pacific Islanders, and 2 times higher for Black or African Americans, 5.4 times higher for Hispanics or Latinos. So we see that again, that the health disparities is very, very, very plain and clear within our own backyard in Maryland. One of the things that I want to share with you is something I'm pretty excited about. About 4 years ago, maybe 5 years ago, time flies, the governor of the state of Maryland created what he called a Maryland Health Quality and Cost Council. And the idea was to try to improve quality while reducing the cost of health care. So he invited me to serve on the committee. And it was a committee with folks from University of Maryland, from Hopkins, from the health department, some hospitals. It was an eclectic committee. And we started with something simple. We decided, this is a pretty large order, and we didn't want to fail. And it was chaired by the lieutenant governor and the health secretary. They chaired it. So we said, let's start with something simple, like hand washing. We can't go wrong with that. So we did, and obviously we succeeded. The idea was how we can get all the hospitals, or at least 80% of the hospitals, to have a robust hand washing program in their hospital. And they had to sign up, and they had to follow the data, and so on. And we decided, let's go a little bit higher. That was a low-hanging fruit, so let's take a fruit a little higher. So we said, let's go to something higher. And we decided, let's go for blood products. And maybe the medical student may not realize that, but when you open a sample of blood, packed red cells or frozen plasma, for example, if you call up to the blood bank and say, I need to have 2 units of fresh frozen plasma or 2 units of packed red cells, once it comes to the floor, it's been thawed out. It must be used or thrown away. So we're thinking, wait a minute now, that's a waste. It's money and it's product that's been wasted. So we develop a system that other hospitals could be notified that this hospital or that hospital is electronic, has thawed out fresh frozen plasma or thawed out packed red cells. And if you need some blood, rather than open up a frozen sample, just call up Hospital X. And that became a real success. So we got courage now. We took on 2 kind of a low-hanging fruit. So I think the lieutenant, one of the sheriffs said, let's go for the real problem, health disparities. How can we reduce it and reduce some costs? Because it's hugely costly. So that was like going up at the top of the tree, having picked off 2 low-hanging fruit. So it was a little hard. And so I was asked to chair that committee. And this is not my area, but I was willing to listen to the public health folks and the health disparities folks, listen to what has not worked. And make a long story short, after we spoke for a while among ourselves, we were there for 3 hours for about 10 meetings. And the only deal I made is that they had to have it in my office. So I wouldn't have to travel to go someplace else. And we came with an idea which I'm really excited about. And the idea was, let's learn from somebody else. Let's learn and see what others have done. And we did a lot of that, seeing what others have done, what has worked, what has failed. And we came with the idea that in industry, they have used an approach called economic zones and have been able to repopulate or re-energize these so-called designated economic zones. How about if we create a health zone? And as we talked more about it, we created the term health enterprise zones. And what it is, and I'm summarizing all that so you can forget the slides, we decided that there are pockets of areas throughout the state of Maryland that have a high morbidity, high mortality, and high utilization of ER and services. But simultaneously, they have low health and social services. How about if we propose to the governor, to this state, that we would like to create these health enterprise zones based on zip codes, the zip codes that have those disparities, high complication and low services. And we propose that the state would create tax incentives and tax credits for services that are not there, to move in, to do loan forgiveness for students, so doctors would move in, to give lower rent on those buildings the state owned, for others to use those facilities. So essentially, we would replete those health enterprise zones with services that they're lacking, using specific incentives for people to come back in. The lieutenant governor, they liked it, they accepted it, and took it to the legislature. And the legislator had to testify a number of times. You know, I could never be a politician. Just so much, you got to go through so much to get sometimes so little. But this time it wasn't little. Eventually, they passed it with $16 million. And so we've created 5 health enterprise zones across the state of Maryland. Let me show you, let me show you the preliminary data, so at least you can see. So the act was signed by Governor Mal in 2012, and it was called the Maryland Health Improvement and Disparities Reduction Act. I told you about what it is, and this is a special time. So I want to look at the data. Here's the data. Again, keep in mind that it was just done in 2012, so there's not a lot of data, but there's some very encouraging data. You'll see the top graph. I'm going to read this for those in the back, okay? It says here, rates of overall preventable hospitalization among health enterprise zones. And you can see that it has gone down from 2009 to 2013. If you look to the right side, is rates of acute preventable hospitalization among the HEZs. And that, when you look at, and they use counties, Annapolis, Dorchester, Prince George's, they're showing a decline in those as well. And it looks next at the rates of chronic preventable hospitalization, and those rates are going down. Now, I want to be clear. We're not involved in this is the health department. We've just made our academic component. We've done the academic side and made a recommendation. I've testified, and they've funded it, and now it's being run by the state. We have nothing to do with it. So these data I've gotten from the state. But the point is, there appears to be some benefit from having these health enterprise zones. I know they've actually recruited a number of primary care physicians that they ordinarily would not have been able to. The people are moving in, they're getting cheap housing, they're getting tax credit, they're getting tax incentives. So there is some added value. Academic medicine coming to the rescue. This is my last slide. And this is a video clip I'll share with you of some of the things that we're doing in the community.
Ready? Yeah.
Every year, faculty volunteers visit a West Baltimore Boys and Girls Club to help underserved children learn about health and fitness.
Don't let your knees bend.
It's an outreach of the school's Mini Med School program, which provides a series of tuition-free classes designed to help Baltimore City residents of all ages improve their health and well-being. Topics include glaucoma, diabetes, and hypertension, issues important to the surrounding community.
It's been really informative because we know the questions to ask. We keep all the books so we can go through them, and we just love, and we will continue to come. And we couldn't have asked for a better program. I mean, you provide everything from the parking, and the meals are plus, but just for the doctors to take the time out to provide the information is truly a blessing.
From West Baltimore to the Eastern Shore and Western Maryland, School of Medicine faculty members have conducted more than 150 free Mini-Med School classes for adults, children, and high school students. Since 2001, The number of participants has grown to nearly 7,000. We are especially proud of Yusuf Ali, who enrolled in mini med school as a college student and went on to become a practicing physician, graduating from the University of Maryland in 2012. The program has made such an impact, the state honored Mini Med School with a special proclamation.
By virtue of the work that the School of Medicine has done around the health disparities, both long before there was a health enterprise zone, the School of Medicine has been a leader in understanding the role that health disparities play and having to decrease assets in our communities. So in addition to that, the School of Medicine makes a difference, helping to plant the seeds for long-term gains in the community.
Community service remains a cornerstone of the student experience at the School of Medicine. Every Thanksgiving for more than a quarter of a century, students have organized Project Feast to feed the homeless and hungry. Students, faculty, and staff gather at a city school to help prepare and serve a hot turkey dinner and distribute donated clothing to those in need.
Thanksgiving is about really giving thanks for what you have and others are not as fortunate.
Through the Student Sightsavers program, medical students provide free glaucoma screening at a city market as they learn about patient populations affected by disparities in care.
Glaucoma tends to affect African Americans more, and so this is a great population of patients to be looking for glaucoma in this patient population.
The Student National Medical Association is so active in the community, it was named the National Chapter of the Year in 2011. Throughout the year, school employees showed their generosity by giving new backpacks and school supplies to support needy children. As evidenced by our annual Mini Med School graduation ceremony, we are a vital part of West Baltimore. We continually strive to address community needs and bring a better quality of life to our neighbors. The University of Maryland School of Medicine, changing lives and transforming our community.
So I'm going to just tell you, this is my last slide. There's this one student I'm particularly excited about. You know, you make an impact, but sometimes there's always one that stands out. Well, these mini medical schools, it's nothing like I've seen before. And again, I'm there 10 years now, so it preceded me, but I've supported it very much. We do it twice a year, and it's 3 hours per night for 6 weeks. We have 300 to 500 area residents who attend. It's unbelievable. I mean, 2 years ago, we did a special award to 35 people who came for 10 consecutive years. Same persons coming over and over. And so I've asked our Department of Epidemiology to actually do a study and see kind of what impact we've made upon those, take a case control study of those who have not come versus those who have come. I mean, I kind of know what my hypothesis is that we would have made a huge difference in their health performance, but I want to see it. I want to see the data. But the student who I find it very interesting is this particular student, Yusuf Ali. The story goes that he dropped out of school. I think he dropped out of high school, dropped out of his house. I don't know where he was living. And a friend of his invited him to come to one of those mini medical schools. It's a big deal. It's a lot of people are there, and there's food, and there's, you can see it's like a little celebration there. So people enjoy coming. Well, he came and he sat and he decided, you know, and then what we do, we have the so-called students select what they want to hear next year. Asthma, diabetes, whatever, AIDS. Just they select, and then we get a flavor. So we invite the faculty to come and make the presentation. So he decided, you know, I think I can do that. I'd like to be a doctor. Well, the guy hasn't even finished high school. You know, so I think I can handle that. So he went back and got his GED. Obviously must have been a bright guy to begin with, but it was all latent. He got into Morgan State University and did very well. As we would say, he aced the MCAT. And so we accepted him. He was so good, in fact, one year I invited him to be my keynote speaker as a student for the minimum. I mean, he was so embarrassed, you know, but I said, you know, he said, Yusuf, you're an unusual student. You need to show it off. He graduated, he got accepted in his top choices to Emory University to get to do his residency in psychiatry. That's right, what it is. And I tried to keep it with him. Where's Yusuf now? He's an unusual story. He's now doing a fellowship at the University of Florida. So I said, we need to invite him back. I mean, this is a great story. But the point I'm trying to make is we can make a difference. We can make a difference locally. We can make a difference globally. Not only can, but we are. So the last slide is a summary. Local and global community health is important for all of us. The good news is that academic medical centers make huge impacts on the major and critical role within our community. Despite the barriers that we face, many are multiple, AMCs have had a lasting impact on our communities locally and globally. We control HIV/AIDS epidemic. We've reduced the burden of enteric diseases worldwide. We have responded quickly and efficiently to emerging and re-emerging public health threats. The AMCs are critical partners in the success of our surrounding communities. And I use the word surrounding very, very generically, maybe immediately or maybe not so immediate. Dedicated efforts to reduce health disparities to the underserved or to even urban populations or rural populations for that matter. Uniquely positioned to prompt culturally sensitive care as well as health education to those who are in need. Finally, creative community-based health initiatives and programs can make a lasting and significant impact on the health and well-being of everyone. Thank you very much.
Thank you very much, Dr. Reece. I want to open up to questions that anyone might have for Dr. Reece. I know there's a question. Dr. Welch, I see one coming.
Okay. So, I spent last week in the UK. I probably should have stayed there.
That was just for you, Dr. Welch.
89 versus 79. And I'd like to probe that a little, get your feeling about it, because it's very clear that we have not done as well as the nationalized or single-payer health systems around the world. We're number 70. Our mortality rate has improved, but we're still number 17 in the world tables, so-called civilized nations. And all the other 16 have got single-payer and nationalized systems. So my question to you is, what do you think that's due to? Is it because of the removal of marketing forces to the delivery of healthcare? Is it because there is a more developed social structure which is going to be, has to be an essential partner to predictive and preventive medicine? Or is it the fact that academic health centers, or what portion do you think that academic health centers must take responsibility by virtue of the fact that we've had a rather elitist attitude to primary care, and that we have not championed primary care and population health to the same degree as we should have been doing during the last 4 years?
Thanks for the question. First of all, I was struck by the statistics, and I was eager to share because I know you'd be here. And I thought you'd have picked up that right away. So you did exactly what I thought. You know, I'm going to share with you, there's a lecture I saw once, and I'm going to pretend I have there's a slide. And just pretend that this is the y-axis, and this is the x-axis. And what is on the y-axis is really mortality rate. And the x-axis is the percent of GDP invested in health, okay? This is a paper done by the Karolinska Institute, and these are the results. What they showed is that in this region of the graph, the sort of for high mortality, low GDP investment, you're having kind of countries that you expect the underdeveloped and maybe some of the developing ones. But as you start to increase your investment more and more, you start to decrease your mortality. So you start to get in this region here, maybe some of the Scandinavian countries, and you know, by the time you get to 18, 19% of GDP, the U.S. pops up there. So you see what is happening. You know, England is way up there too. I'm going to ask you a question for the audience. Which country in the world do you think had the lowest? There are a few that had low, but I want to add the lowest. Had the lowest amount of investment, economic investment as measured by GDP, but had performance rate, mortality rate or survival rate, which you want to call it, equivalent to the United States? That's a question. You think I should repeat the question? Sure, it's a question that I think I'm going to use to respond to Dr. Welch's question, why I believe there's a disparity in, say, the single-payer UK, Scandinavia versus the US. All right, since nobody's jumping up and answering, Cuba. Cuba has 9% of its GDP invested in healthcare. America, how much we have? 18, 19%. So what Castro says, I can't afford sick care, so I have to invest in healthcare. I have to prevent people from getting sick. So it is believed that countries that have a formalized preventive health program, a requirement almost. Jamaica has actually a low GDP. I think it's like 12%, something like that. But they also have a pretty close to America. Everybody is required to have a vaccination. Not suggested, it's required. Water, sanitation, preventive health is it's not authoritarian, but it's pretty close. When you say everybody, in order to go to school, you got to have all your vaccinations, and before there are nurses. So I think one of the reasons is that because we're such a egalitarian, so we're very democratic, then there are some people who don't think they need to have vaccination for their children. You know, that is a fact. I'm not making it up. And so there's some, until recently, preventive medicine, preventive healthcare was not reimbursed. So as a consequence, preventive healthcare was basically done only if you could afford to pay for it, or you did it yourself. So people basically went to physicians when they got sick. And I would say almost every physician in this audience will probably can testify to at least one patient, I'm guaranteed it's many, that you know you could have taken care of if they had insurance. Every one of us. So, Dr. Welch, I think the answer to your question is that the single-payer system, because it's universal, socialized, and this is not advocating for one or the other, and to get political, just to say that I think because of that there is a much greater emphasis on preventive care because it's already paid for, as opposed to our system where, until recently, preventive care was not paid for by the insurance companies, and you'd have to do it out of your own pockets. That's my short answer to it. It's a lot more, it's more complicated than that, but that's at least a good start.
Well, I'm going to thank you once again for coming, and certainly you'll be here for at least 3 more minutes to answer any other questions people will have. But I do want to also thank people who helped bring Dr. Reece here today, like Jessica Reynolds and Sarah and Lisa, and as well as Martha Bates' department. So thank you very much for everybody for coming, and thank you, Dr. Reece, as well, for that very inspiring talk.